Welcome to the Perinatal University Advanced Fetal Monitoring FA Bundle Course presentation. I'm your instructor, Carol Curran, an OBGYN nurse practitioner and perinatal clinical nurse specialist. Our first topic in the FA Bundle Course series is entitled 2008 NICHD Updates, Guidelines, and Terminology. It is evident with communication errors, number 1, and orientation and training, number 2, improvement in intrapartum care is warranted. Following the release of the 2004 JCO Sentinel Event Survey publication, ACOG and A1 adopted the 1997 NICHD nomenclature as the national standard of care for interpretation and communication of fetal heart rate data among all practitioners skilled in electronic fetal monitoring. Both EFM strips are examples of hyperstimulation. In our last section of this topic, we will discuss 2 recently published articles of interest to the obstetrical community. The original authors utilized a 3-tier system to define the gravity of the deceleration into mild, moderate, and severe. Data is outlined on this slide based on the mean pH and 1 and 2 standard deviation values. Today we will complete a case review from real-life obstetrical clinical scenarios. In following NICHD guidelines, this 14-minute sample strip contains 2 optimal areas for a baseline assessment. The presence of an abnormal baseline rate places this pattern into NICHD Category 2. There were rumors that there was a woman in the clinic that was a cardiac transplant patient. So we were all a little bit worried about it, and I remember approaching one of the perinatologists who was excellent in her field, and we loved her. And I said to her, I said, I hear from the residents that there's this particular patient over in the clinic. And she said, well, yes, the rumors are true. And I said, well, what can we expect? What do we need to do? And she said, well, we're not really sure that she's going to make it through second trimester, but if she is, we'll develop a plan then. The evolution of uterine activity, decelerations, and fetal heart rate patterns over time assists the perinatal team with the maternal fetal care plan. The evolution of uterine contractions into tachysystole may warrant alterations in induction medication administration. Variable decelerations may evolve in frequency, depth, and duration. The evolution of variable decelerations from intermittent to recurrent or from mild to severe offer insight to evolving fetal hypoxemia. Patterns that evolve from NICHD Category 1 to Category 3 impact bedside practice. Therefore, identification and management of fetuses at risk for evolutionary changes is key to patient safety and improved fetal outcomes. Evaluation of acid-base status tells us about oxygen transfer at the cellular level. This slide illustrates the diffusion of oxygen from inside the blood vessel out into the peripheral cells and tissues. As hypoxemia reflects peripheral desaturation, cellular alterations are noted by hypoxia. Hypoxia is defined as a decreased amount of oxygen in the tissues. This EFM strip occurred immediately prior to delivery. What was the umbilical artery pH? This pattern has been linked to an intrauterine fetal condition confirmed by ultrasound. In sample B, the fetal heart rate continues for 13 minutes of bradycardia. These metabolic acidosis results would most likely accompany strip B. This strip evolved from minimal variability and 1 8-minute prolonged deceleration 2 hours preceding this strip into 17 minutes of bradycardia. This discussion will offer recommendations and guidelines for incorporation of the new 2008 NICHD 3-tier fetal heart rate interpretation system into practice. During all non-reassuring conditions, non-invasive strategies should always be initiated first. These should be followed by any invasive procedures or interventions. If all first and second line maneuvers appropriate to the clinical situation have been initiated but fail to improve maternal fetal conditions, then delivery is warranted through the most expeditious route. In 2007, the Institute for Safe Medication Practices added IV oxytocin to their list of high alert medications. Most importantly, oxytocin errors are generally preventable. Therefore, let's take a look at intrauterine resuscitation techniques to limit the effects specific to this drug. As we begin our brief discussion on oxytocin management, one must remember the goals of therapy. Stimulating or augmenting labor to promote fetal descent and cervical dilation is the #1 goal of any labor enhancement medication. The uterus is similar to a sponge. Oxytocin receptor sites catch and absorb the molecule which stimulates the uterine muscle. Applying more drug onto the existing receptor sites at a frequency exceeding the medication's pharmacokinetics leads to excess. Are there any other maneuvers to perform which may improve this tracing? The team has utilized a number of interventions listed here. Overall, the team has done well. As outlined in Lesson 5, oxygen therapy should be a short-term second-line therapy. In this lesson, we begin with a discussion on communication techniques that enhance collaboration among perinatal team members. These skills and techniques may be applied to our next 3 objectives. 3 clinical or practice scenarios will be explored for risk of miscommunication. Verbal communication and documentation recommendations are outlined for each scenario.
I want to know why the Pitocin was turned off without a resident's knowledge. This patient was here to be induced, and she's been without medication for almost 2.5 hours. This is ridiculous. How do you nurses think that you can just come in here and run patient care? You need to turn on the infusion immediately, or I will speak to your unit manager.
Hey, I just got here. I didn't turn it off. I'm sure the other nurse probably had a good reason to do so, but you'd have to check with her instead of me. Maybe the repetitive decelerations and poor variability had something to do with it, but that's just me. The third-year resident was just in my office. I had to apologize to him for your behavior this morning. Nurses need to understand that the residents are in charge. I don't need this stress. More outbursts like these may impact your employment in the future. Are we clear? In July 2009, ACOG updated their practice management bulletin for intrapartum fetal heart rate monitoring. This has led to an increase in interdisciplinary education and training.
Now, Miss Blake, if you were confused, as you stated, about the fetal heart rate, why did you not notify somebody of your concerns?
I did. I did go to the nurse's station and ask Nurse Jones and Nurse Jackson if they thought anything was wrong, and they said no.
Did the 2 other nurses ever go to the patient's bedside to evaluate the patient?
No.
Did you ever request for either of the other RNs to go to the patient's bedside to evaluate the strip and/or the patient?
Not that I recall. Medical legal malpractice involves determination of cause with the question, was the injury avoidable and foreseeable? This means, could the perinatal team have foreseen the outcome with the current plan of care? And could they have intervened differently to avoid the injury to the patient? This concludes our presentation of the 4th topic in the FA Bundle Course series entitled Acid-Base Analysis and Methods of Interpretation. You may now proceed to the next topic in the series. Thank you for your time and attention. We appreciate your participation in our program. Have a wonderful day.